4, 3, 2. Good evening. This is Dr. John Bennett broadcasting from Miami, Florida. Tonight, this is a continuing series of educational videos for Parkinsonism, and we are graced by the presence of Dr. Abdul Rana. He's a neurologist from Toronto, Canada, and he's a world-renowned Parkinsonism educator. And tonight, Dr. Rana is going to be talking about the difference between Parkinsonism and Parkinson's disease. Good evening, Dr. Rana.
Good evening, Dr. Bennett. Thank you for the opportunity to talk about Parkinson's disease tonight.
Very good. Very good. Let me start things off, Doctor, by asking you, are Parkinsonism and Parkinson's disease different?
Parkinsonism is a non-specific term and is used for symptoms like the slowness of movements or stiffness or rigidity. It could be due to many diverse causes. It could be as a result of drugs or many other secondary reasons, is applied relatively loosely as compared to Parkinson's disease, which is a specific disease entity. And Parkinsonism could be a primary, which is idiopathic or Parkinson's disease. It could also be secondary due to other causes, and in some cases it could be hereditary neurodegenerative causes. With respect to Parkinson's disease is a specific entity which has a clinical definition and a pathological definition. Although for Parkinson's disease there is no consensus or a definite criteria, but most experts think that with bradykinesia or slowness of movements, if a patient has either rigidity or a resting tremor and a response to levodopa, it is usually Parkinson's disease. Whereas in case of Parkinsonism, so when patients have either bradykinesia or rigidity, and usually they have other symptoms as well. This term is used relatively loosely.
Okay, how is Parkinsonism classified?
The main cause of Parkinsonism is primary Parkinsonism, which is Parkinson's disease. It is idiopathic, and it makes up to 80% of cases of Parkinsonism. In addition to this, there could be secondary causes, as well as atypical Parkinsonism or Parkinson plus causes, and then neurodegenerative or hereditary causes. With respect to the secondary Parkinsonism, it could be drug-induced, such as antipsychotics, the dopamine blocking drugs, which are used very often in patients with psychosis or schizophrenia. And in addition to them, there are certain drugs such as dopamine depleting drugs, rezapine, as well as some of the drugs like lithium or flunarizine. They could also cause the drug-induced Parkinsonism. Some of the infectious causes, such as in early 1900s, when they had encephalitis lethargica, which affected hundreds of thousands of patients, those patients also developed the symptoms of Parkinsonism. They had oculogyric crisis, as well as slowness of movements, and some of the toxins could cause secondary Parkinsonism as well, such as carbon monoxide, carbon disulfide, or exposure to manganese, or MPTP. MPTP is quite well known especially in the research for Parkinson's disease, because this is the toxin which was contaminated in the heroin. When some of the college students were making the synthetic heroin, and they ended up in the same hospital, and this is how they found that MTP caused symptoms like Parkinson's disease. And these days MTP and MPTP has been used in research for Parkinson's disease when the experiments are done on animals by giving them MPTP, and symptoms like Parkinson's disease are induced so that they can be studied further. Some other causes, such as certain parts of brain, if they have small infarcts or small strokes, they could cause vascular Parkinsonism. The vascular Parkinsonism is quite different from the idiopathic Parkinson's disease, as vascular Parkinsonism usually affects different sites of body, like mostly lower bodies affected. These patients have more problem with gait as well as balance. They could have a freezing of gait, and usually if you examine them in upper extremities, like you ask them to do finger tapping, opening and closing of hands, and hand turning repetitively, so their movements are quite good, and they are symmetrical in upper extremities. But if you ask them movements of leg agility, they are slow. Also, if these patients walk, they have a typical gait. They have small steps and a short stride and slow speed. So main problem in these patients is the involvement of lower body with symptoms like Parkinsonism. So another type is hemiatrophy, hemi-Parkinsonism. In these patients, one side of body is affected, but these patients usually have either a hypoxic insult at the time of birth, so one side of the body does not develop as good as the other side, and there are symptoms of Parkinsonism seen on that affected side. It may be smaller than the other side. The two sides of body may not be equal, although the difference is subtle, and this condition progresses slowly, but these patients do manifest symptoms of Parkinson's. Sometimes other conditions, like if basal ganglia tumors or patients with hydrocephalus, they could be mistaken for Parkinson's disease, and they are also sometimes considered secondary Parkinsonism. These patients with hydrocephalus, especially, they have trouble with their gait. Their gait is magnetic. They don't lift their steps off the ground, and they have trouble with their balance because of their gait, and they also have some subtle cognitive changes. So they could be confused with Parkinson's disease. And certain metabolic conditions, such as parathyroid disorders, could cause secondary Parkinsonism as well. The patients with secondary Parkinsonism it can be differentiated from idiopathic Parkinson's disease relatively easily, because idiopathic Parkinson's disease usually starts on one side of the body. It usually starts in the arm or upper body with slowness of movements, or people are noted to have less arm swing on that side, and they are lagging their leg or their whole body when they're walking. So it's quite asymmetrical, the idiopathic Parkinson's disease. The third cause of Parkinsonism is atypical Parkinsonism. The main types of atypical Parkinsonism are progressive supranuclear palsy, multiple system atrophy, and corticobasal degeneration, which we see very commonly in day-to-day practice, especially those physicians who deal with the Parkinsonism or movement disorders. Patients with progressive supranuclear palsy, they usually present with history of falls. So they would fall without any warnings. They could be standing in a kitchen or anywhere else, or walking, and they would just fall backwards without any reason, with no no apparent causes. They don't have any features like seizures or cardiac arrhythmias or stroke, and they would just fall. There is no change in level of consciousness. There is no shaking, twitching, jerking, tongue biting, or incontinence of bowel or bladder. And this is how these patients are brought to the attention of the physicians. When you see them, these patients have stiffness or rigidity, which is more axial. Like their neck is more rigid as compared to their upper extremities. And also, if you ask these patients to do finger tapping, opening and closing of hands, and hand turning, so they could be quite good, and they will look very symmetrical. There is no apparent asymmetry, and then these patients in the beginning could have some cognitive changes. Their speech may be affected. They have difficulty with swallowing. So these type of symptoms usually do not occur in idiopathic Parkinson disease in the beginning, of course, of the disease. Because in idiopathic Parkinson disease, it takes a few years before patients run into trouble with their cognition or speech, or they start falling, or they develop postural instability. Whereas patients with progressive supranuclear palsy, they develop postural instability in the beginning of the disease. And then when the condition is a bit advanced, then you see trouble with their gaze. So these patients have a difficulty with their lower gaze, so they can't, they have trouble looking down. So coming downstairs, which involves lowering the gaze, is quite difficult for these patients, as well as sometimes reading becomes a problem, and eating from a plate in front of them becomes difficult for these patients because of their gaze problem. They also develop a typical facial appearance in which their nasolabial folds and the frontal folds are quite prominent, and you can see the deepening of these folds. So this is how these patients with progressive supranuclear palsy, they can be differentiated from idiopathic Parkinson's disease. Whereas patients with multiple system atrophy, these patients usually are brought to attention because of dizziness. They are lightheaded because they have autonomic dysfunction, which starts in the beginning, of course, of disease. Autonomic dysfunction also happens in Parkinson's disease, but the autonomic dysfunction in Parkinson's disease starts after several years of the disease, usually. Or if it is relatively early, it is very subtle. Whereas in patients with multiple system atrophy, these patients have lightheadedness, and when they stand up from a sitting or a supine position, their blood pressure drops, they become dizzy, they start falling because of dizziness. And also these patients, they have gastrointestinal problem, they have trouble with gut, and they have diarrhea. Sometimes it could alternate with constipation, and also these patients could have a cerebellar type of tremor. They don't have a resting tremor, which you see typically in Parkinson's disease, but they have a cerebellar type of tremor. And also these patients lose sexual functioning, and they could be quite young. We have seen patients who were in their 40s and they lost sexual functioning, which is quite unusual. So when you see these patients with the loss of sexual function and lightheadedness and very prominent autonomic dysfunction, and usually their bradycardia is symmetrical on both sides of body, and they have history of falls due to lightheadedness. So this can be differentiated in idiopathic Parkinson's disease. In the beginning, of course, of disease, sometimes it could be somewhat difficult to differentiate the two conditions, especially if patients with idiopathic Parkinson's disease, they don't have a tremor, so it becomes a little bit difficult to differentiate them from atypical Parkinsonism if the symptoms are subtle and they are not just limited to one side. Another type of atypical Parkinsonism, which we see relatively commonly, is corticobasal degeneration. These patients with corticobasal degeneration, at the onset of disease, their disease is quite asymmetrical. So they develop trouble with one side of body, and they develop a dystonia. The dystonia usually involves their hand or fingers of hand or arm, and interestingly, it is asymmetrical like Parkinson's disease, but patients with Parkinson's disease, after maybe a couple of years or so, after some time, their disease becomes somewhat symmetrical, or it may remain slightly asymmetrical. But corticobasal degeneration patients, they maintain their asymmetry of symptoms throughout the course of disease. So they always have that one arm which becomes functionless. They cannot use it, so they could have trouble with their speech and slight difficulty with cognition. In late stages, they could develop some gaze problems, and these patients also have difficulty with their balance. In addition, they could have seizures in some cases, so they could have a phenomenon called alien limb phenomena, in which they would report that their arm does things on their own. They would say that this arm had mind of its own, it does things on its own. So that's very typical, although seen not very frequently. So patients with corticobasal degeneration may also be difficult to differentiate from idiopathic Parkinson's disease in the beginning of the course of the disease. So these were the main types of atypical Parkinsonism which we see: progressive supranuclear palsy, multiple system atrophy, and corticobasal degeneration. So in addition to these, there are certain neurodegenerative familial conditions which have features of Parkinsonism, such as Huntington's disease. Patients with Huntington's disease, they have a chorea, which are the movements of different body parts, and they seem to be flowing, and they are repetitive, involuntary movements. And these patients develop speech problem. They have a typical lurching gait, and they could also slowly develop trouble with their cognition. There is a atrophy of basal ganglia when you do MRI in these patients. This is a familial condition. And Wilson's disease is also familial. It has trouble with the copper metabolism, and these patients have typical faces. Their facial appearance is quite dystonic, and from their face you can see the appearance. And so these patients may have combination of various movement disorders. They could have a wing beating type of tremor. Sometimes they could have a chorea as well as dystonia. The other types of familial neurodegenerative conditions we see are familial basal ganglia calcification, or familial Parkinsonism with peripheral neuropathy, neuroacanthocytosis, or OPCA. These are very rare type of conditions, which even in movement disorder clinics are not very common. So this was the fourth type of Parkinsonism.
Thank you, doctor. Why is it important to differentiate these conditions?
There are several reasons. Because of this, we have to have a clear idea about the condition of the patient, whether this is idiopathic Parkinson's disease, or it is one of the Parkinsonism, either atypical or familial or secondary, because of the prognosis. Because the prognosis in idiopathic Parkinson's disease is much different than these conditions. Some of the atypical Parkinsonism cases, such as progressive supranuclear palsy, as well as multiple system atrophy, they have a worse prognosis as compared to idiopathic Parkinson's disease. So we have to inform patients about their expected life expectancy, or what they should expect in future. So another reason is the treatment response. When you give levodopa, which is also used in many other causes of Parkinsonism, when you give levodopa to these patients, so patients with idiopathic Parkinson's disease, they respond very well. As I mentioned in the beginning, that some of the experts, they take this as an assurance that the diagnosis is correct if patient responds to levodopa. And if patient does not respond to levodopa, then the diagnosis of idiopathic Parkinson's disease becomes questionable. So for the response, the expectation of the patient, so we have to tell patients that if we think that they have idiopathic Parkinson's disease, so then we tell them that when you take this medication, you should see a significant improvement in slowness of movements as well as stiffness, and your tremor may somewhat improve, whereas in patients with atypical Parkinsonism, this is not the case. Atypical Parkinsonism and Parkinson plus condition and secondary Parkinsonism are so complex that sometimes we cannot predict the response of these conditions to levodopa. Being a student of movement disorders and neurology myself, I sometimes tell patients that because your condition is so complex, so it's really difficult to give you a verdict that you take this medication and either you would not improve at all or you would improve, because some patients even with atypical Parkinsonism, they could show a relatively good response as compared to other patients. They would not show much response to levodopa. So expectation of treatment is very important for patients to know, as well as their caregivers. And then another reason is that in patients with Parkinsonism, they have some other symptoms associated with them which need to be treated, such as patients with MSA, multiple system atrophy. They have autonomic dysfunction, which you need to treat, lightheadedness, postural dizziness, and they have sexual dysfunction. Patients feel very uncomfortable discussing this with the physicians, but you have to bring that into discussion so that you can improve the quality of life of patients. So these conditions these other symptoms associated with these conditions are very important to screen and to treat, because patients may not know that these symptoms are part of this condition. So you have to initiate the discussion that, do you have this symptom, do you have that symptom? So then you go according to the response of the patient. So and also in patients with atypical Parkinsonism, such as progressive supranuclear palsy, they are at risk of falls. Especially in the beginning of course of disease. They indeed are presenting to you with the history of falls, whereas this is not the case of idiopathic Parkinson's disease. They don't have falls in the beginning of the condition, so you have to address the falls. So you have to tell them that they have to watch their balance, they have to rise gradually, they have to start, they have to wait before they start walking. They should avoid sudden rising and especially turning. So, and they should use a walker, because patients sometimes feel it, they feel it as a stigma using a walker or a cane. So you have to educate them that fall prevention is very important. So these things have to be done in the beginning of course of disease in patients with Parkinsonism, whereas in patients in idiopathic Parkinson's disease, in the beginning, the major cause of their presentation is usually motor symptoms, slowness of movements, or tremor. So if you address those, and then as you see them in follow-up visits, you can screen them for other non-motor symptoms which can be treated as time goes by. And in addition to these, cognitive dysfunction usually happens early on in patients with atypical Parkinsonism. So you have to treat cognitive dysfunction. Sometimes they may have blepharospasm. Patients with atypical Parkinsonism are particularly, they have more prevalence of blepharospasm, although this can happen in idiopathic Parkinson's disease as well. So the treatment is different. And this is such a condition which can cause patients to have a functional blindness. So you have to treat these patients. So from this perspective of the prognosis, the expectation of treatment, the future course of the disease, because patients have to make their arrangements, their caregiver and family has to know that what they are looking at, and then the treatment of the associated symptoms of atypical Parkinsonism as well as Parkinson's disease. So from these points of view, it's quite important that the physicians may try to make a clear distinction in patients with idiopathic Parkinson's disease and atypical or other causes of Parkinsonism.
Very good, doctor. I think that wraps it up on the difference between Parkinsonism and Parkinson's disease. And thank you very much. And we'll be continuing this series probably tomorrow night.
Thank you very much, Doctor.
Okay, doctor. Thank you very much, and we'll see you tomorrow.
Good night.
Good night.